why diabetic ketoacidosis is more commonly seen in type 1 diabetes mellitus and less commonly seen in type 2 diabetes mellitus, and why ketogenesis, ketone body formation, only occurs in diabetic ketoacidosis but does not occur in another acute metabolic complication of diabetes mellitus, which is hyperosmolar hyperglycemic state, HHS. So both HHS and DKA, diabetic ketoacidosis, are acute metabolic complications of diabetes mellitus. Both are associated with high blood sugar level, hyperglycemia. But one of them, DKA, is associated with ketone body formation. Another one, HHS, is not associated with typically high level of ketone body formation. What is the reason behind this? Answer of these two questions we try to understand in this session, in the second part of the diabetic ketoacidosis. Now, both of them, the answer of both these questions lies connected with two concepts. I would explain one by one. Number one concept is this, that type 1 diabetes mellitus is a state of absolute deficiency of insulin. That means in type 1 diabetes mellitus, what happens? Hardly there is any insulin present, little or no amount, because most of the insulin secreting cells, the beta cells in the islets of Langerhans, they get destroyed by the T cell mediated autoimmune process, T lymphocyte mediated. Type 2 diabetes mellitus is a different problem. Type 2 diabetes mellitus, insulin secretion may be impaired, may be low, but never as low or absent like type 1 diabetes mellitus. In type 2 diabetes mellitus, more important problem is insulin resistance. The insulin which is there, which cannot act on its receptors on the peripheral tissues. That is the major problem. So one state, type 1 diabetes mellitus, is in an absolute deficiency state of insulin. Type 2 diabetes mellitus is a relative deficiency state of insulin, which is also associated with insulin resistance. Please keep this concept number one in your mind, because I am going to tie this with another concept which would explain the answer of both the questions. Second concept is this, that insulin also shows a differential sensitivity to carbohydrate metabolism and lipid metabolism. Or in better way to say this, that even at lower level of insulin, low amount of insulin can suppress lipolysis activity, the degradation of lipid activity. They can suppress the activity of the hormone sensitive lipase, which causes typically lipolysis. I already explained this concept in the part 1 of the diabetic ketoacidosis, because this is actually this excessive activation of the hormone sensitive lipase is there, which causes the ketone body formation, the DKA. Now, differential sensitivity of the insulin on the carbohydrate metabolism and on the lipolysis, it basically means this, that even if insulin is present in very low amount, still that insulin can still suppress the lipolytic activity. Even it is not very high, but if it is even present, still it can suppress lipolysis activity. But at that small amount, it cannot promote the glucose utilization. So utilization of the glucose by the insulin, that means utilization of the peripheral tissues, suppression of the gluconeogenesis, suppression of the glycogenolysis. These carbohydrate activities can only occur at a higher amount if the higher amount of insulin is present. But even relatively low amount of insulin is present, it can suppress lipolysis, or they can suppress the activity of the hormone sensitive lipase. Then connect this concept with which I taught in the part 1 of the diabetic ketoacidosis. The main reason I told you the ketone body formation occurs in diabetic ketoacidosis is this, that as insulin is hardly present, because there is an absolute deficiency state of insulin in type 1 diabetes mellitus, what happens? That absolute deficiency state cannot even suppress the hormone sensitive lipase. So, as a result of activation of hormone sensitive lipase, peripheral adipose tissue starts to be degraded, and they makes more amount of free fatty acid, and those free fatty acids come via the blood into the liver and get converted into the ketone bodies. This is happening in the type 1 diabetes mellitus more commonly, because type 1 diabetes mellitus is associated with absolute deficiency state. So, but in type 2 diabetes mellitus, what is happening? insulin level secretion may be impaired, insulin level may be low, but never as low as type 1 diabetes mellitus. So that low level of insulin which is present in type 2 diabetes mellitus, they can suppress the lipolysis activity, they can inhibit the activity of the hormone sensitive lipase to stop ketone body generation, but that low level of insulin which is present in type 2 diabetes mellitus, they cannot promote the glucose utilization activity. So as a result, what is happening in type 1 and type 2, both cases in DKA and HHS, both cases you will be getting the presence of hyperglycemia, because hyperglycemia, to stop that would be stopped in neither of this condition, because the amount of insulin is required to promote glucose utilization that is present neither in type 1, neither in case of DKA nor in case of HHS. But as DKA requires an absolute deficiency state of insulin, and DKA typically occurs in type 1 diabetes mellitus for the same reason, because type 1 diabetes mellitus is a state of absolute deficiency of the insulin where hardly or almost no insulin is present, that total absent or near total absence of insulin is not enough to suppress the lipolysis activity. That is not enough to suppress the activity of the hormone sensitive lipase to stop degradation of the lipid by the hormone sensitive lipase, because insulin normally inhibits the hormone sensitive lipase. So as in type 1 diabetes mellitus, it is an absolute deficiency state of insulin. So that absolute deficiency state of insulin, that very low level or hardly present in insulin, that is not enough to suppress lipolysis. But in type 2 diabetes mellitus, the main problem is insulin resistant and still some amount of insulin is there. That insulin is enough to suppress the lipolysis activity, to suppress the degradation of the peripheral adipose tissue into free fatty acid. And that is the reason DKA also typically occurs in type 1 diabetes mellitus, sometimes can occur in type 2 diabetes mellitus, sometimes. Why it can occur? The principle is same. To cause diabetic ketoacidosis or ketone body formation, you need to create a state of absolute insulin deficiency. Now, absolute insulin deficiency can occur in type 2 diabetes mellitus. Let's say if the counter regulatory hormones of the insulin, the hormones which oppose the act of the insulin, let's say catecholamines or growth hormones or any other, cortisol, their level increases, cortisol, catecholamine. This typically happens in stress states, like you have an infection or stress state. So in type 2 diabetes mellitus, let's imagine that there is a 3 unit of insulin is there. So that it is not I'm just telling by example 3 arbitrarily. And it is not an absolute deficiency state of insulin. But if the counter regulatory hormones which oppose insulin, they rises very high. Let's say it becomes 5 unit, the level of catecholamine, the level of cortisol. Why they will rise? Because if you get DKA in type 2 diabetes mellitus, it will be seen in those scenarios where there is a stress. It could be an infection or any surgery or any after that, where there is a excess counter regulatory hormones which oppose the action of insulin, their level rises. So the amount of insulin which is there in type 2 diabetes mellitus, they become basically zero, because this counter regulatory hormone rises and they make it negate. So that create an temporary absolute deficiency state of insulin even in type 2, and that case again DKA can rise. But the principal concept is this, that to cause DKA, you need that absolute deficiency state which is normally present in type 1 diabetes mellitus, and that's why it is more common in type 1 diabetes mellitus. It can occur sometimes in type 2 diabetes mellitus, but it can only occur if the state of absolute deficiency is seen. And the concept that why ketone body formation occurs in the DKA is also explained by that concept, that there is a differential sensitivity, very low amount of insulin, very low amount can suppress lipolysis activity, but that cannot promote the glucose utilization activity, because there is a differential sensitivity of the insulin to the lipolysis compared to carbohydrate metabolism in glucose utilization. That is the two concepts which basically explains both the answers of this question, that why ketogenesis, ketone body formation is only seen in DKA and not usually seen in the HHS, and why DKA is more common in type 1 diabetes mellitus. Thank you so much.